Welcome to Conversations in Interventional Cardiology. I'm Dean Kereiakes. I'm chairman of the Christ Hospital Heart and Vascular Institute in Cincinnati, Ohio, deputy editor of SCAI, and a professor of clinical medicine at The Ohio State University. I'm honored to be here and representing SCAI and also the editor-in-chief, Alexandra Lansky. You can find us online at jsci.org or on X, previously Twitter, at myjsci. I'm here this evening with Neel Butala, who is the assistant professor of medicine at University of Colorado Regional VA Medical Center in Aurora, Colorado. Bobby A., professor of medicine at Harvard University from the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center in Boston. Margaret McEntegart, the director of the Cath Lab at Columbia University Irving Medical Center in New York Presbyterian Hospital, and Jennifer Rymer, who is the John B. Simpson assistant professor of medicine at Duke University School of Medicine. And we're here to discuss a very interesting and important paper entitled The Use of Calcium Modification During Percutaneous Coronary Intervention After Introduction of Coronary Intravascular Lithotripsy that appeared in SCAI this week. DISRUPT-CAD3 demonstrated that coronary IVL was safe and effective in modifying calcium prior to DES implantation. Shockwave was approved and commercialized. However, I think the clinical use of a novel technology in real-world clinical practice outside the pristine confines of a IDE clinical trial are of great interest to all of us. Neel, Bobby, and Jennifer have made very important insights regarding the assimilation of coronary IVL into clinical practice, and they're here to discuss those findings. Neel, welcome. We're interested in hearing what you found.
All right. Well, I appreciate the opportunity to be here on behalf of my co-authors to talk about this manuscript out in SCAI this month. Here are just our disclosures, and this work was funded by SCAI and supported by the SCAI Shockwave Medical Early Career Research Grant. So a little bit of background: calcified coronary lesions represent a challenge for treatment with PCI. A variety of treatment options exist for calcium modification traditionally. Recently, coronary IVL has been approved for use in coronary arteries, but limited data exists on contemporary use of calcium modification strategies during PCI, and particularly after the introduction of coronary IVL. And so we sought out to examine trends in use of calcium modification strategies, as well as hospital variation in use and predictors of use of both calcium modification strategies as well as IVL for PCI. We used the NCDR CAP PCI registry dataset, looking at all PCIs between April 2018 and December 2022. This is over almost 3.5 million PCIs. We excluded patients with STEMI, with shock, cardiac arrest, and our final cohort had 2.7 million PCIs. So first, we looked at trends in use of calcium modification strategy among patients undergoing PCI. And here you could see, starting in Q2 of 2018, approximately 9% of all PCIs were done with calcium modification. This increased slightly to about 11% by Q4 of 2020, and then began to suddenly rise to 16% in Q4 of 2022. And this was driven largely by IVL, which increased from 0% in Q1 of 2021 to nearly 8% in Q4 of 2022. With a subsequent decrease in use of atherectomy. And this slide just breaks down the use of atherectomy and IVL among patients undergoing PCI by the type of atherectomy. And here you can see both orbital and rotational atherectomy decreased, while IVL increased. Notably, there is over 3 times use of rotational in conjunction with IVL compared to orbital in conjunction with IVL. Next, we looked at hospital variation in use of calcium modification. And here you can see a really wide spread across the sites in the study. The top 5% of hospitals use calcium modification in up to 31% of PCI, just in 2022 alone, whereas the bottom 9% did not use any calcium modification for PCI. Similarly, we saw wide variation in use of IVL across hospitals, with 26% of hospitals not using any IVL. Again, this is in 2022. And the top 5% using using IVL in 17% of all PCIs. In looking at use of IVL as a calcium modification strategy, we saw, again, wide variation. But the most interesting thing here, I thought, was that IVL is now the most common calcium modification strategy in nearly half of all hospitals. Again, this is in 2022. I'm sure things have changed since then. And then looking at hospital variation and use of calcium modification for PCI over time, we basically see that the introduction of coronary IVL in 2021 has made the use of calcium modification for PCI more widespread, as evidenced by this orange area relative to the size of this green area in terms of change over time. We looked at predictors of calcium modification use during PCI, and here we saw that the hospital treating hospital site was a primary predictor. And we found the median odds ratio here be nearly 2.5, which indicates a 2.5-fold difference in odds of a patient undergoing PCI receiving calcium modification at one random hospital versus another. So really, the hospital that a person gets PCI at is the strongest predictor of whether they get calcium modification for a PCI or not, controlling for a number of other factors. Same thing, looking at predictors of IVL use among PCI with calcium modification. Again, we found a nearly 3-fold difference in odds of PCI with calcium modification receiving IVL at one hospital versus another, as measured by this median odds ratio. Again, indicating if you're getting calcium modification, the hospital you go to determines in large part the strategy that's chosen to treat in terms of PCI. So to summarize, we found that coronary IVL has changed the landscape of calcium modification used for PCI pretty rapidly. There's been a rapid uptake in use of coronary IVL after its commercial introduction in the US, which led to an overall increase in use of calcium modification for PCI with some displacement of atherectomy. We found wide variation in calcium modification use and IVL use. And finally, we found that the strongest predictor of use was treating hospital site. So I'll stop sharing there, and I look forward to our discussion.
That was excellent, Neel. Excellent. Bobby, do you or Jennifer, who were co-authors on this, want to add anything at this point?
So I think a couple of things really stand out here. I think the wide variation, first and foremost, with just calcium modification techniques across the U.S. is really sort of astounding, and maybe a little bit surprising that, almost a third of hospitals in the U.S. are not using calcium modification techniques. But I don't think it's surprising that IVL has necessarily been taken up so rapidly. I think it's very attractive in that it's very similar to balloon angioplasty from a sort of a technique. I think it's attractive to maybe operators that are not necessarily using atherectomy on a wide basis, but are obviously very familiar with balloon angioplasty and could sort of take that up. I think that we still have a lot to learn about the overall the technique and its success and outcomes in patients. But I think we shouldn't necessarily throw out other atherectomy techniques. I think in terms of IVL overall, it can be somewhat difficult to pass, and I think oftentimes it does need to be used in conjunction with the other rota and orbital atherectomy. So just sort of those are my overall thoughts. I think the variation was astounding, but then not surprising, I think, that it's been taken up so rapidly.
Yeah. Bobby?
Yeah, I think that it's really unique. If you think about what's been happening in the coronary space for the past decade or two, certainly the past decade, what have been devices that have really transformed the landscape of coronary intervention in the past decade? I don't know that we have that many of them. Certainly a couple decades ago when DES came out, that was really revolutionary in how we treated patients. But since then, can't think of a device that has changed how we do PCI procedures as rapidly and dramatically as IVL has. I think if you were to follow these curves out to 2024, you would only see continuation and maybe even an increase in the slope of that growth curve potentially. The other comment I would make is it is, really privileged to work with Neel and Jen and others on this, using the NCDR data set to do this, which is really our nation. The U.S. is best ability to track these devices and really understand how they're used in the real world after we had limited, I would say, pre-market evidence to support them. And so it's just nice having the ability to be able to follow what's happening nationally with a procedure like this from the ACC data sets.
Yeah. Margaret, what do you think of the data presented? Are you surprised in any way?
So first, congratulations, guys. Really fantastic paper. I really enjoyed reading it, and a really interesting perspective. Yeah, I think a few interesting reflections. I think, first of all, we all love new technology, anything that kind of makes our procedures easier. But it's quite interesting to see that after an expected surge with the new technologies, as Bobby said, very sustained and continuing to rise, unlike some of the other technologies, for instance, orbital, etc. So I think that's interesting. And I think also, around the calcium space, we don't have much evidence, and we obviously have all the single-arm disrupt trials. So despite no randomized data, I think in clinical practice, I think that indicates to me that people see how usable, how easy to use, how effective, and also, I think very importantly, safe the device appears to be in routine clinical practice. And I think that's also borne out when you look at some of the predictors and demographics, older patients, very high proportion of frailty, etc. So I think it kind of I think what you see in the data is that what was a new technology has sustained and grown in usage because of people's experience of using in the clinical space, I think.
Yeah. I've seen very few things take off like this. And Bobby, I probably would go back to maybe Cypher Stent that had some of the same, checked many of the same boxes as a revolutionary kind of, but this even more so. It fills an unmet need. It fills a void. And then it checks boxes of safety, efficacy, ease of use, and the secret sauce, incremental reimbursement. At the end of the day, it really helps boost the exponential curve of that line that you're describing. Cypher got that. This IVL got that. But other technologies, some of which I think you don't need to learn a new technique, as Jennifer pointed out. I don't care if you're an interventional cardiologist, vascular surgeon, or a cardiology fellow, the first thing you use is a balloon. And they've packaged leading edge technology into a primitive. Now, you showed disparities in utilization, which I was actually surprised at. I really am, particularly for women. It's a highly significant differential. And I've thought of IVL as being the great equalizer in women, despite smaller caliber vessels, more tortuosity, more diabetes, and many of the analyses. The paper that came out in SCAI last year with Alexandra Lansky in Frampton basically showed women had a lower number of MACE and TLF at 1 year than men, absolute lower number. And we're not used to seeing that with ablative technologies. Can any of you comment on that?
So I think, Dean, it reflects the lower use of lots of things in the female patient. So we see lower use of physiology, lower use of IVUS, etc. Lower use of atherectomy, but with more hazard. So I think it's probably, I was surprised as well, because to me it's a very reach for device in the female patient. But it is interesting to see that kind of pervasive approach to PCI in women has even continued with the early using of IVL, but hopefully maybe we'll turn that around as we gather more data in that space.
Yeah. Can any of you comment on the selective? It seems to be, and I noticed this initially, if you look at atheroblative technologies drifted downward, kind of in symmetry, IVL took off. But the ratio of rotational to orbital is less than twofold greater rotational compared to orbital. But when you use it with IVL, there's clearly well over threefold relationship. So there seems to be either preferential or selective use of rotational atherectomy in conjunction with IVL. Any explanation for that?
I think I have some ideas about it. I think, the attraction of orbital atherectomy was always this idea that you could maybe get calcium that was deeper than you could with rotational atherectomy. But rotational atherectomy has always been the mainstay for things like balloon uncrossable lesions, or things where you thought you'd have a lot of trouble getting initial equipment across. Now that IVL really its mechanism deals with superficial and deep calcium quite well. And in those situations where you have balloon uncrossability or difficulty, then rotational atherectomy is the right device for that. So that combination, they seem to not really compete. I guess there's some displacement, but they compete with each other in a way, I think, less than orbital atherectomy would compete with IVL.
And I think some of it's just been somewhat marketing as well. I always think it's important to sort of bring that up, but I do think the rotational atherectomy is really marketed to some degree as can be used in conjunction. And so a lot of, rota IVL, so rotational followed by sort of touch-ups with IVL. I see that in common practice. And so I think it's both a mechanistic, but also maybe a marketing strategy as well.
Yeah, to that point, Jen, it reminds me, Dean, of your comment about the reimbursement. I mean, I think a cynical view of the growth would be that the reimbursement pushes the growth in a way that is out of proportion to the evidence. I would say in this particular case, we're seeing these curves occur before the DRG codes and the CPT codes were out. So there was really not physician reimbursement for this. Mm-hmm. And the hospital reimbursement was really limited to the sort of transitional codes and the pass-through codes, and those codes, as part of the breakthrough technology, at least in the outpatient setting, don't actually cover the full cost of the device. So I think the curves that you see here, the growth, actually don't reflect this sort of cynical view of physicians trying to make money for themselves and for their hospitals, but actually true clinical value that the physicians were seeing. Now, what we see going forward, I think, is going to reflect a combination of those things after the full reimbursement came. But these curves here, I think, do represent true clinical growth.
Yeah, no, I agree with you, Bobby, but hospitals have a way of manipulating physician behavior by not putting it on the shelf. Mm-hmm. And if they're taking a loss, there are hospital administrators that'll see that it's not on the shelf. And that bottom 5% or whether you had where there was no use, it would be very interesting how and why that occurred. Inexplicable. So I really don't know. I think the other thing is a perceived safety. When we, in the paper, we did the first, 628 combined CAD 1 through 4. We had 0 perf, 0 abrupt closure, and 0 no reflow after IVL alone. And it was really, and we know that nothing remains 0 forever. But this is really just truly remarkable, different experience than what we've had with other calcium modification techniques, and particularly atheroablative or even laser. Does anybody have any other comments regarding that? What you think really drove this? Was it the safety and efficacy, the ease of use? I mean, it's hard to ferret that out.
I think that I agree with you. I think ease of use, obviously, but I think when you're using it, I think on particularly these tough lesions at steep bends or lots of tortuosity, and I think there's a bit of fear potentially about using a rotational orbital atherectomy and what could potentially happen. And I think with IVL, particularly if you've gone in and you've done balloon angioplasty and then you start to recognize I'm not going to get adequate expansion, I think there's maybe more of a likelihood to turn to IVL than to pull out after multiple balloon sort of inflations, atherectomy at that point. So I think that that's one thing. I would be interested to know what folks think about the variation. So it seemed like, and I thought this was just fascinating from Neel's paper, just the variation in hospital use of atherectomy overall, but then IVL, and how do we sort of standardize practices going forward so that that there's not 30% of U.S. hospitals that are not using any of these.
Well, that and Neel, one graphic you guys, Jen and Bobby, didn't put on there was if you had color-coded on-label versus off-label use. Think about that. Mm-hmm. It's That would be insightful if you wanted to create a graphic like that, because in my opinion, I would say there's more off-label use right now than there was, quote, on-label. Although the PAS that we did post-approval study with 1,212 patients showed that despite having the same INE as CAD3, they were older, they had more hyperlipidemia, more prior CABG, more renal insufficiency. I mean, it was a higher risk group of people in those 1,212, but the mortality is 21% lower than what we saw at CAD3. But that was discrete. We excluded, basically, think of what CAD3 excluded, and that's a labeled indication. So I'd say most of what you showed on your graphics is not CAD3 type patients. Margaret, do you think that's true?
Yeah, I think that's true. And I think a couple other things I think would be super interesting. I know that we don't have any data relating to imaging, but I kind of instinctively feel that if you're a really high imaging site, I think that probably drives diversity of device use, because you really look at the morphology and you kind of try and tailor the device to what you see. And I think that would be super interesting to work that out. I think maybe if you're a low imaging site, you maybe gravitate towards one or two devices or approaches. So I think that would be interesting. The other thing I thought was interesting was the combination therapy use. So I think it was 1 in 10 calcium modification cases had combination therapy. And interestingly, the half of them were combination with cutting and scoring, and half of them were combination with atherectomy. And that kind of makes me think, okay, the cutting and scoring are the cases you think the calcium is more moderate, and you start with cutting and scoring and you escalate to IVL. And the atherectomy ones are you maybe start with the atherectomy and then you realize you also need IVL, like the uncrossable lesions. So they've kind of got both ends of the market covered, so they're like the go-to second device if it's more moderate, and they're the go-to second device if you're really dealing with severe calcium. So I think that's quite interesting. Maybe accounts for some of the exponential growth.
I may have missed it, but what was the incidence of imaging used here, Neel? Did I miss that? So
it's a great point. It's actually a limitation of the CAP PCI registry that imaging is not well captured. And it'd be great to know more about these lesions in a more descriptive way. But going back to other points, I think a key thing that this study that doesn't quite come out in the slides we showed is that there's almost different phenotypes of hospitals, which could indicate different phenotypes of operators, where there's this group of hospitals or maybe even operators that are used to sort of NC balloons and cutting balloons, kind of stops there. They may not have on-site cardiac surgery. They may be sort of a lower risk kind of community type center. And there's a phenotype of hospitals that do sort of the high-end atherectomy and more complicated patients. At least based on what I could gather is, IVL is actually, a lot of the operators in the sort of community practice who don't see the high complexity stuff actually gravitate towards IVL. And some of that, I think, has really enabled them to use calcium modification, whereas they wouldn't have otherwise. So I think that's a huge sort of way that IVL is expanding the pool of treated lesions and people that are actually getting, theoretically adequate expansion of their stents with calcium modification. And whether that leads to improved outcomes is, still to be seen, but it certainly sort of fills this gap, as you were saying, in this sort of community practice setting where it's sort of ease of use is a big
well, the SCAI consensus document, Bobby, you guys know this, said it was okay to use in hospitals and labs that didn't have surgery on site, et cetera, unlike rotational atherectomy, et cetera. I'm not sure you capture all that utilization in this database, do you? What are the limitations with respect to use of coronary IVL, which, unlike rotational or orbital atherectomy, are going to be confined to certain hospitals that have on-site surgical backup? This really was, the appearance was safer, less likely to perforate, and you could use it in the smaller hospitals with less surgical on-site. Do you think you missed a number of the data points here with this?
So we are able to assess whether sites had on-site cardiac surgery or not. So that was one of the variables.
You have how many total hospitals contributed to the database?
I don't remember off the top of my head. I could pull up my slides, but it's it represents, I think, over 90% of all hospitals doing PCI in the U.S.
And when you do that, did you separate them by on-site surgery or non-on-site surgery? And did you see a significant differential?
Yeah, so patients, hospitals that had on-site surgery ended up having, they're 1.3 times more likely to use IVL as opposed to another modality of, so 30% more likely to use IVL as opposed to another modality of calcium modification.
Yeah, one thing here, so I think that we're looking at these numbers and we're not in steady state, like these data, include the first few months to the first year where really there's rollout. And I mean, this is maybe part of the reason that explains the hospital variation. And it also may explain some of the, for example, the racial disparities that we see in access, which are, when companies roll out new devices, they go to particular sites first. They go to the sites that were enrolling in the clinical trials, and they go to major metropolitan areas. And sometimes those don't serve a representative cross-section of the United States. We're getting treatment with coronary disease. And as a result of that, and they don't, go, and they're not representative of physicians who are necessarily doing coronary angioplasty in the US. And so you may see wide variation, particularly in the initial phases of a technology rollout, in part due to the way that technologies actually disseminate into practice, into hospitals, how contracts are made, et cetera. So I think we'll see, the other aspect of it is, to your comment, Jen, earlier, and to Margaret's, for better or worse, and probably for the worse, hospital variation and operator variation is the rule rather than the exception in interventional cardiology. And, it's true for transradial access. It's true for imaging. It's true for this as well. So in some ways, maybe it shouldn't be so surprising, although I might hope that as we reach more of a steady state with this technology, that you would see, more opportunities for standardization and maybe more, homogeneity in use across different places.
I thought you guys did a phenomenal job. I really enjoyed it and enjoyed seeing the data. It was more dramatic than I might even have predicted, to be honest. And I think you're right. The line's going to keep going, but there are going to be other players on the field as well. There are other types of atherectomy coming of, let's say, lithotripsy or other calcium modifying technologies that will be coming down the pike. That I think may give them a run for the money. We'll see, depending on the key factors of ease of use, safety, efficacy, and then cost, incremental reimbursement. So I really appreciate having each of you here. I appreciate the time. Neel, Jennifer, Bobby, great job on the paper. I'm really proud of what you were able to do. Margaret, thank you for being here and adding your perspective. Thanks to everybody for listening in, and real thanks to SCAI for sponsoring these conversations in interventional cardiology, which I think give a perspective on publications that you can't get anywhere else. So I'm happy to be part of that.